I'm here at Orlando at the 61st ASH, and it's a big year for myeloma. There's some key topics that have been covered and are about to be covered in myeloma in the next couple of days, and probably one of the things that is getting people most excited is the CAR T-cells. So CAR T-cell clearly have proof of principle in ALL and in non-Hodgkin's lymphoma, and have been approved by regulatory authorities around the world, and their target has predominantly been CD19. The first CAR T-cells target initially actually was CD19, but now BCMA or B-cell maturation antigen is the primary target for CAR T-cells, and there's a number of types of CAR Ts that are using that as a target. And without going through every study one by one, there's a number of key principles that have come out of CAR T understanding in myeloma. Firstly, it works. It's yet to be approved by the regulatory authorities, but there's no doubt CAR Ts in myeloma are here to stay. It's a matter of how effective and managing toxicities and maximising the response rates. There are various different types of CAR Ts, and we've heard a lot about the different types, and I think what we're trying to work out right now is, are the response rate differences across the trials, which are being done at a number of institutes, predominantly in the US and China, are the differences due to different patient populations, particularly their prior therapies? So patients who've been exposed to, that are quad refractory, in other words, refractory to proteasome inhibitors, IMiDs and monoclonal antibodies and chemotherapy, transplant, etc. Whereas some of the patients have had minimal amounts, a median of 3 prior treatments. And there's also clear differences in the type of CAR T, the engineering behind it. And some of them look very, very potent, and others have quite variable side effects. So it's interesting looking at potent CAR Ts with minimal toxicities, and there were some interesting presentations from both the US and China, where we're seeing studies that show minimal toxicity, high efficacy, others with much higher toxicities. So I think CAR T-cells response rates have been very, very promising, 80% plus for basically every study. One study this morning had 100% improvement, but again, that is very much about patient selection. The second big area is monoclonal antibodies, particularly daratumumab, and the results of the upfront treatment of monoclonal antibodies, both in the pre-transplant and in the transplant eligible group, and then in the transplant ineligible group. And so those results are all coming out positive, and I think this is going to be a big change in myeloma in the next few years. So I think the game changers that are coming out of ASH are clearly CAR T-cells and upfront use of monoclonal anti-CD38 antibodies.